Buenos días.
Good morning. I hope that you have rested well and that you're strong and have, for our second day of our conference, it's going to be very interesting. And particularly, we're going to focus on knowledge and information about glucogenoses from a multidisciplinary point of view. And in our first two presentations this morning, we shall look at training in these pathologies. We shall speak about the viability, feasibility, the effects in type 3 glucogenosis. And to stride ahead, we shall also look at the nutritional guidelines indicated in these conditions. We shall not leave the clinic aside. We'll speak about experiences also and muscle problems. And in the afternoon, we shall participate in a panel session where we shall underscore the importance of nutrition as well as of exercise in GSD. And we shall now begin, as I'm already mentioning, speaking about the importance and the feasibility of training in glucogenosis. We have multisystemic effects of exercise, the influence in muscle function, and glucose metabolism. What type of training would be good? The tolerance would the person might have with this exercise. And so we're going to give answers to questions with regards to these issues. In the second presentation, we shall have, firstly, we have Dr. Alfredo Santalla from the Pablo de Olavide University. We shall now give him the floor. Good morning. The bad thing about being the first one is that people are still tired from last night's dinner. And first of all, I should like to thank you for getting up so early to be here and for the association for having invited me to give a lecture here. When I chose the topic of my lecture, it seems to me that this isn't working for me to show you my slides. When I chose the topic, yes, now it's working. Yes, I thought I'd speak about training in glucogenosis where there was evidence, and actually there was very little. So I'm going to give an endeavor to try of speaking with patients and why this happens and what we do in laboratories and why we use these training. And I'm comparing you with a car overhaul. We're looking at different parts of the car that need to be remedied, that they are not working well, they need to be fixed. So we do an overhaul of the cylinder block, of the engine, what have you, and we have different types of training here. Training for people and then the technical inspections with cars, and I'm comparing the two. Now the checkup and the overhaul of a car engine. Firstly, I'd like to mention that exercise doesn't cure, but it helps a great deal. It has limitations. It's coadjuvant. It's useful with glucogenoses, but it's not the panacea either. Notice here we're speaking about the heart. Well, there's quite a bit of evidence. I'm not going to speak much about the heart because Alejandro and Lucía will do it later on. But basically, look at sees the heart and the different involvement here. We have the pulmonary hypertension, hypertrophy, and even for this exercise, we know that it can't cure, but it can counteract or mitigate these conditions. There are guidelines about exercise with Pompe, which recommend an exercise guidelines, and when particularly if there's a heart involvement of this disease, VO2 maximum goes up 10%, and this with you doing the given regimen for several weeks, and we measure the oxygen whenever people come to the laboratory. This is especially functionally. It shows how much oxygen our lung can ventilate, with how much strength the oxygen is pumped to our heart, and of course we want to see how much oxygen our muscle can use, and the fat, and a bit of blood glucose in the case of glucogenosis. So it's an integral value which is worth looking at. And in the case of glucogenosis, the hepatic kind, and we see fat in the muscle. We're speaking about Pompe and the limitations, the heart limitations. There are other more complete tests which allow us to find out how much the heart pumps, systolic volume is so much, and we have these types of evaluations. But oxygen consumption in a stress test gives us a great deal of information. And also, sometimes there are GSDs where there is no standard for training, but underneath you will see we have the ERS statement on exercise training and rehabilitation in patients with severe chronic pulmonary hypertension. And I think that we can adapt to exercise to mitigate pulmonary hypertension. And the idea behind training, and I'm going to mention these things to you with training, these are ideas to share, and this is to try to change the muscle cells of these cardiomyocytes. What happens in heart conditions, cardiomyocytes, they thicken, they're hypertrophied. For example, that's not good because we see the heart there on the bottom, the walls thicken, but the ventricular cavity increases. So in any person, not only in GSD, but you're stretching those cardiomyocytes without increasing the size. And if you do this, look at this heart. The walls are more or less the same, but the diameter of the ventricle fits more. It fits more. So how can we stretch these cardiomyocytes? There's a better capacity here, and we will have more mitochondria, the capillaries. There'll be more glucose. There will be more fuel, in other words. Also, it's simple to do. Let me explain what I mean. This is a stress test, and so axis we have more exercise here. This is our work ratio in watts. It's in watts here, work rate. And then we're going to look at the heart rate, the liters per minute of the heart rate, and we have 19. And this is done because the heart rate goes up about 170 pulses here. And the systolic volume is what we see here on our chart. And if you notice that we have the plateau, and there's in each beat there's no more pumping. This is where we have to work, do something. Here's an example at 60% of the maximum rate, about 50% of oxygen consumption, and we have eccentric load by stretching these cardiac muscles. And with this, they increase in length, and they have more capacity. And if I increase the intensity, look at the systolic volume, it either loses a bit or it says it's stabilized. That's not bad either, but there's the contract force is increasing a lot. The way the muscle pumps that blood. I'm not interested in that in the hepatic GSDs. Excuse me, the speaker says, the heart GSDs. I'm not going to speak about the heart anymore, but the hypertrophy ratio, they compare the relative wall thickness, and then the hearts respond to this type of training. So particularly we have our 130, 135 pulses a minute. We want to be having the heart work to increase the length of these cardiomyocytes. Let us continue with our technical inspection here. And group the muscle GSDs have all of these problems. You're familiar with them, cramps, pain, and I'm going to speak about training again. Why does one train? Basically, we want the muscle to have a better structure, more brake strength, and we want to see how much oxygen can be consumed. And here, in many GSDs, we use aerobic muscle strength plus respiratory muscles. And here we have our muscle cell. The aerobic is to use the fuel. And then, of course, in Pompe, if there is diaphragmatic involvement, as we saw yesterday, we're also going to have specific training for these respiratory musculature. Notice that almost everything can be trained. What do we do with the 3As or the myocardials, and what can be done with any type of glucogenosis or GSD? Very simple. What is a stress test? It's a patient has to pedal, so there will be the ATP will be manufactured just because we have blood glucose, muscle glycogen, or hepatic glycogen. And you can imagine if a patient does more exercise, the muscle recruits fibers, different fibers, which are specialized in different types of metabolism. This is a test for any one of us who does not have GSD. What about the energy in each metabolism? We see that type 1 fibers are very lipid dependent. They consume fat, mostly fat. And then we have the 2A, they are glycogen dependent. They're aerobic and anaerobic in red. And then, even though they consume glycogen, they're specialists in phosphogens. And they produce ATP phosphocreatine and use this fuel, glycogen, glucose, and lipids. And if we maintain this energy and that's stored in the muscle, then there can be physical exercise done at different intensities. And so, obviously, if we're lucky, we'll have our VO2 peak, and that which the muscle uses to oxidize this fuel. So this curve, now we're on our maximum heart rate. And so there's a bit of a change here when we refer to GSDs. From the beginning, we don't have part of this fuel, sometimes in the liver or liver plus muscle, with which we need to improve the fat issue. And we have the 3A and the 5, the myocardials, looking for an intensity about 50-60% of the consumption maximum or peak, and notice these examples, and we play with the heart output, cardiac output here. And myocardial doesn't have anaerobic metabolism, and it just uses blood sugar. The blue curve is also quite low, as you can imagine. And the recommendation of carbohydrates a bit before exercise is to fill this little bit of this tank with blood, so it goes through the muscle, and it gives off this glucose, and so the muscle has more fuel. And look at this intensities close to the maximum use of fat. This is how people are trained. And you reach 50, if it's just 50%, you can't achieve if you get to reach the limit to stress all of the enzymes. Okay. When one is trained at this intensity, you change. There are metabolic and structural changes of the muscle. There will be more mitochondria, more blood capillaries, for which there will be more glucose to the muscle, and also I can make more capillaries, and they're full of blood. I don't have arterial hypotension, and I work in the green area where there's fat. I'm going to show the mitochondria to use more fat and not use so much glycogen. So, and we have this intensity here, and if I have a lot more blood, and each diastole, I'm going to stretch those chiromyocytes more, and we'll get the frequency we want. So in the end, we're going to get what we want. But when we're focusing on the muscle, this is the technical inspection of the car, and there will be an improvement of the fat intensity capacity, and there will depend less on glycogen. This is regulated more because of the glycogen problem. This is what we do with training. When there are more mitochondria with our muscle plasticity, this happens in any kind of training, but we call that muscle transition. And these fibers, which are more glycogen dependent, change and they become more lipid dependent. So our gasoline engine is becoming a diesel engine. And so this is because sometimes there are limits. But anyway, this is what this training is all about. And this is what we're looking for. So this would be useful for all GSDs, this manner of thinking, this mindset, in other words. So in green, in glucogenosis, is not the same. The curve, look at what the curve does. It goes down. In myocardial, we see that the green curve of lipids is this way, goes up. Lipolysis depends on cirrhosis, and myocardial, they can't decompose this. So the data say that it's exactly the same in other times. In McCardle, they're more trained, and when they're highly trained, let's say over here, we can improve the fat function. If there's a great deal of intensity here, it's nice that we use the glucose with a bit of blood sugar to maintain this high intensity without having any pain. And so this wouldn't be this. So here, if we're going to the right-hand side, it's not the same. It's not this in the 3A. It's not intensity. So notice this recipe isn't the same for everybody. You've got to do a stress test and use other types of tests to be able to ascertain this. So the evaluation is highly important, and depending upon the evaluation, how each person responds, then we would have to design the exercise program. Now the liver involvements. It might help, not so much as with heart or muscle involvement, but this just shows you how training helps these glucogenosis with liver involvement. Those who have the liver involvement are familiar with this problem here. Exercise, the muscle does exercise, the heart pumps blood. There is no capacity to use glycogen, or most of it anyway. Theoretically speaking, the energy goes down. Let's see the effects. The liver, if it's not hepatic, it can release its glycogen, but the hepatic ones, this is impossible. What's going to happen? Obviously, we're going to look for extra muscle fuel, well, cornstarch before training, for example, but very easy to have low blood sugar. And so we can do different things. We can increase just a little bit the dose, just a wee bit, enough to satisfy the exercise demand, not much more, because what we don't use will be accumulated in the tissue, obviously, and obviously at the same level. And with supplementation, this cascade also appears in protein situation. They're more protein, their breakdown here, then there's a low blood sugar, and fat is oxidized to be fuel for the muscle, and then by sending just a bit to the liver to reconvert them in the ketones, and then it's an emergency. They're ketonic bodies, and then you notice it's not good for it to go up too much. If it goes up too much, it means that metabolically speaking, with fat, protein, and carbohydrates, the muscle is using more than it is receiving. You can know that if with physical exercise I can break fat down better, then this has an incidence in the control of glycemia. It helps, not as much as to modify a heart or a muscle, but as you can see, it's not bad. It's an exercise which is interesting, and we are reducing adipose tissue, fatty tissue. These are basic ideas about how one trains. The title, which I thought about, makes me wonder about evidence in training with GSD. Not too much. Look at it in 2022. These people reviewed all of the studies, and I'm adding to see this was a systemic review of investigating the effectiveness of exercise training in GSD. So notice the evidence here of these studies, which it's a report of a couple of patients, and it's just 58 patients. Yesterday, Jordi was mentioning we've got to bear this in mind because just with 17 or 20, the evidence is what it is. But in rare diseases, it's very difficult to recruit patients and to have them be training for 3 months. And the protocol that you have designed for X time and traveling and going from one city to another to see these patients is difficult. So these are ideas for other people with GSD. Why are there contractures? What are the problems with the muscle? As a muscle contracture is that filaments of myosin are stretching, and they're in this area where there's actin, there's ATP, where there's energy. When this energy is full of energy, these little white dots, it comes and goes, and the contraction, muscle relaxation begin. What is that? It is calcium. That's calcium, basically. I fear that this projection has been blocked momentaneously. Can someone help me, please?
No sé. Al control suprimir quizá. Vale. Cerrar programa. Ya parece que reacciona, ¿no? A ver. Me voy donde estaba. No, aquí no estaba. Dame un momentito. Aquí. Me salto la animación esa.
I'm going to skip that animation. I'm sorry, this little video clip was the only thing I didn't check beforehand. Sorry about that. So I'm going to explain why there is muscle damage. And this is now a diagnostic cycle test for myocardial disease. Well, the heart rate goes up a bit, but in all of the GSDs, we have muscle pain and muscle contractures. Basically, what is happening at that moment, notice they can't degrade glycogen, these filaments, they can't break them down. And then we have ATP, and notice what's going on. There isn't much strength, but this calcium, which was helping with the filaments to help those filaments relax. And what happens if the calcium can't be used, it gets stuck, and then everything gets stiff, and everything doesn't function well. So they're always removing sodium, so it's not accumulating, and it puts in potassium. So if sodium and potassium don't work well, it removes water, and then a cell that is full of sodium and all that they break. So when a person, and the myocardials, for example, they're highly sensitive in this area, then their energy drops because this is low intensity energy, and so proportionately the pain they perceive increases. The three not so much, but in myocardial, their pain is spectacular. Energy drops, muscle pain, and the perception of pain increases because of the contracture. It's an energy storage. It should always be full. What happens to the myocardials, anecdotically speaking? When it's 7-8, for example, the muscle temperature uses the capillaries, and then there's more blood flow to the muscles. Glucose goes in, and it goes from the blood to the muscle, and what happens? Energy is recuperated, and pain disappears. And in the myocardials, specifically, the heart rate goes down. This is a second breath phenomenon. And, well, what about the dilatation of the capillaries? This is valid for most of the muscle GSDs. You can imagine that if I increase this blood just a wee bit, the glycemia level for the capillaries, this stage is less painful. It's easier to bear. And many years ago, this was a study we did with the association. Basically, with this training, we wanted to improve the fat. At 6 months with pedaling, there was an improvement in the peaks, and we did it at watts per kilo of weight. Later, Alejandro will speak about oxygen, but this is a parameter which is quite important. And here, there are many markers, which I'm sure you're familiar with the famous serum CKs. Well, 2,000 at rest went from to 600 at rest, and then 2,000 went down to 700 and some. So notice how interesting that is. So if there's a great deal of intensities in any GSD, well, the 2X fibers will work a great deal. They use phosphogenes, ATP, and for example. And so look at these. We have different seconds where we do this. If we do it at high intensity, this energy will drop quickly, and the muscle will look for glycogen to continue with physical exercise. You can imagine how since this is so fast, energy might drop too quickly, and the person doesn't have time to perceive the fact that he is hurting himself. And there is a sprint, and then when you realize, you think, I've already hurt myself. Here the trick is, if this lasts for 10, 12 seconds, we don't know, then we would have to see the duration in each patient. The trick. This contraction just lasts 6 seconds. 6 seconds. So it's 3 minutes between series. So the trick is to have very short series and 3 minutes, just a wee bit more, between each series in the same muscle to restore that phosphocreatine. Because glycogen and glucose isn't oxidized. That's 7-10 minutes. We just have to see, but for Atari it might be possible. And with this methodology, with very few repetitions for series, then we have the good densitometries, and we can measure the muscle fiber and so forth. And we did this study some time ago, and there is a good response with hypertrophy when there were stress tests. These were the McArdles. They respond better than we do with good training. Their muscle mass improves better than ours does because these stimuli would be compared with muscle damage. And here in this study, we didn't check the strength. We checked the potency. It's force plus velocity. Power equals force plus multiplied by velocity. Few reps. And here in leg press, and we did a chest press, and we'd using more kilos of weight. If I have more kilos, the muscle strength will improve, but there will be a drop in the velocity. At the end, what's going to happen? The strength goes up, and then it won't be the maximum load, and then it begins to drop. So here we stop the test. It's safe, nothing happens. And we see the power, the muscle power, and we see how many kilos this value has reached. So they train for 4 months. So we have some of those volunteers. Notice in the power or the kilos when we stop the test, we did the sit-up and so the chest press, and we did this in just 4 months. They respond very well to this, but if you use few kilos and they do 20, 30 reps, they use up the fuel and the contracture is incredible. You have to work on this. It was difficult to carry out at that time because, well, come to the gymnasium, drink a lot of work, come to the lab, we're going to do these different power exercises, but notice the CK in black and then in blue after the training, and they were stable. First month they go up. The CK goes up the first month, as I say, and after that the muscle creates more tissue than it destroys. And that's why they were stable. Here at month 4, they had 1,500 instead of 2,000 and some, but they were doing a lot with their sit-ups. And we have this video. It's of one of the McArdles with this methodology. And a person with GSD could never even do this, at least in McArdle. McArdle does this with 2 years of training with this methodology, a good rehab, then a good. So then with this young boy, you add 40 kilos with 20 reps, you just destroy him. This is the idea. So we did a 2-year follow-up. We looked at those McArdles, and some did what they complied. There was good compliance with them, and the ones who did not comply, I put them in this other area. And what happened here in this 2-month period? 2 years. I checked the difference of oxygen consumption, and depending less on the glucose compared to those who did something but they did not reach that recommendation by the WHO, 5 days of aerobic a week. I think Dr. Sumi spoke about this the other day, and speak about this, the increase. It says a lot about the muscle limitation. When we see this, we have the maximum yield here, and here we have densitometry here in red. It measures the muscle, and in this last chart, you see the power each muscle can move. With this active training, every kilo of muscle can generate more capacity, so that has more capillaries, mitochondria, everything we're looking for, without needing to biopsy anything to be able to measure this. This is just an estimation. But what I've been telling you, and the idea of training, is it's been shown here in these studies that have been published in the second pathology, where there is scientific evidence in Pompe. This is a GSD2. I don't have experience with Pompe, just with McCardle. We began doing this not long ago. But in Pompe, there are very good studies, and we see that the McCardles they have more of an involvement. And this is the 3A, but this was 2023, and this was 24 Pompe patients. So in the end, there were 163 GSD2s. This is a bit complicated, but this is the number we have. This review checked all of the studies, and look, the aerobic studies with these typical combinations: aerobic 30 minutes, strengthening several days, more repeats than lifting heavy weights. And so how did oxygen consumption change? Notice in yellow, I'm showing you where the improvements. Oxygen consumption increased, and the studies that measured the strength, aerobic and strength, everything improved. There were ventilatory function did not improve much, and functional capacity and well-being that Jordi mentioned yesterday, the six-minute walking test, go up 4 steps, get out of a chair, get up from a chair and walk upstairs, so forth. Notice 3 out of 4 studies there was an improvement, but in the other that wasn't even measured. This is aerobic plus strength. What do these studies tell us? They have 29 subjects. That aerobic does improve the peak VO2, and that it improves the strength, muscle, hip, quadriceps, ischiotibials, and functional improvements in the activities of daily living, fatigue, pain. 5, 10, 12% improvement is shown here. So the ERT is good here. So, and you said there are doubts with the pulmonary function. We haven't done many tests with spirometry. Now, they checked this with the training, and they checked the diet. We looked at the nutrition, aerobic exercise nutrition, and they checked the peak strength using ergometry. And notice these activities of daily living, walking, going upstairs, getting out of a chair. There was no difference in the 6-minute walking test, but in general health or vitality. Then there are other studies, but we've had so few patients that we really can't say. With 47 subjects, we've had volunteers, and the magnitude seemed more so when exercise is combined with diet instead of exercise alone. So we checked the time, and we had reports, and we only had a few subjects, but we extrapolated 3 subjects to see what would happen in all Pompes. That's really not particularly realistic. Improvements are incredible, but just 2 or 3 subjects or individuals. So in this case, what can we learn? That aerobic exercise plus strength improves. If I were a Pompe patient, I would be doing this all my entire life. But with my lungs, look at next to the last column, there's no difference. Yesterday there were problems. We were speaking about Pompes, we were speaking about spirometry. This is a test and it doesn't really tell us, spirometry gives us information about the lungs, but not the muscles. And we see about ventilation, we see FVC, forced vital capacity, but in the spiratory pressure, the MIP, and we have MIP and EP, we notice here is just breathing in and breathing out, but you see the pressure your muscle can generate, muscle strength, inspiratory, expiratory, in breathing in and out. And then here we see different devices. We show that there's a resistance here with inspiration. This is just shows what this device, if you breathe in, it'll give you a lot of resistance, and you're going to strengthen your inspiratory breathing muscle. So now you need to work, and you can improve this situation. Because, for example, when your abdominal muscles are strong, it pushes the diaphragm up and everything is improved. So in Pompe, you heard yesterday about respiratory involvement. There are many studies about inspiratory and expiratory training in Pompe. And notice here, respiratory muscle training and in the Pompe patients. And we have the MIP and MEP. Notice I'm not going to delve into the loads or anything, but we have inspiratory muscle training. As you see on the chart, the pulmonary capacity improves, and 20-40%, I'd give thought to this. The study improved the quality of life associated to this training. And here with this, this is inspiratory and expiratory muscle training, always. And here there aren't differences between the groups. But notice there's a group, 50 to 70 is the percentage. This is the sham placebo. It worked at 15. It wasn't a true placebo. They measured the flow capacity to remove air when one coughed, for example. But notice the study improved the 6-minute walking test to walk a bit faster, improved the time in going upstairs, improving in activities of daily living, improving to go up 4 steps, for example. It improved the sleep capacity. And then they looked at the daytime sleepiness, for example, and other motor functions. But what do these studies tell us? There were 7 studies with 60 people. We see the importance of MIP and MEP. Fatigue is reduced, but we're not clear because just 1 out of 7 studies, just 1 has shown an improvement of activities of daily life. But this is what aerobic plus strength does. So this question was looked at this. This is a chart by Dr. Smith yesterday. And look at we see the maximum inspiratory pressure and the expiratory pressure. There's an improvement in the inspiratory. The little white diamond shows the results, and the other diamonds are studies that have been published of this. Inspiratory pressure in Pompe. So it's better to do this than not to improve the inspiratory pressure. This is a meta-analysis. It's a technique that is used. This is a systematic review, and it's also a meta-analysis. Daily life, 6-minute walking test, but look at the functional endurance. So we don't really bear that in mind. Well, if I were a Pompe patient, I would have aerobic exercise and breathing exercises. Dr. Smith mentioned this yesterday. Retrospectively, not 2 years, but the McCardles, but 10 years. They looked for Pompes, and there was an experimental training study. And afterward they said, who trains and who does not, comparing those who were training for 10 years and who were 10 years without complying with these measures, the WHO recommendations. This is what the patients look like, but when we did measurements, where are their differences? Look at 19 plus what we'll look at the results here. And here we see, look at the difference here in these physical inactives. Look at the p-value. Look at the next value, watts per each kilo of body weight, if you want that for each muscle. Our leg muscles, it's double. It's twofold, from 0.7, not complying with the norms, to 1.7. 1.4, he says, the double of watts per kilo of weight. So it went from 1.4 to 0.7. That's the comparison of the actives compared to the inactives. So oxygen consumption gives a lot of information per heart, pumps, and Pompe don't have so much experience, but it helps the breathing muscles. They get stronger. Instead of 80%, which is the average with control without GSD, the physically active patients had a better result in quality of life questionnaires. And they wanted to see how much they moved every single day, how much they walked, and they were much better off if they were always active, always physically active, a lot of training. And again, you don't see it in gain, but as time progresses, you don't lose as much as those who do not train at all, who are completely physically inactive, in other words. This is the aerobic plus strength plus respiratory exercises. So with many different conditions, and not just glucogenosis, it's a combo that works really, really well with the examples I've shown you, stress tests or just the spirometry measures or PIMs that I've talked about. So that combo, aerobic plus strength plus respiratory in a nutshell. And this is a summary. What about scientific evidence in training? We have Pompe. I didn't talk about 3A because Alejandro's going to talk about 3A, and also in McArdle, the evidence with lots of studies. But there are also interesting studies with the response to exercise. All of these up here, plus more. And no training, then tests with different types of GSDs, and there was an article that showed how the hearts respond, how their muscles respond, how much they consume. And with these studies that have been published, it's that we can now easily design a training program. So we've done this, and there were studies about all of this. This was relatively simple. And so we do these tests with which, even though we just have evidence in 2 or 3 types of GSDs, there are studies showing how important training is. And to take home messages, I don't know if I've spoken too long, but we've seen that there's evidence in Pompe and McArdle that any muscle that one trains can improve, and at long term, it loses speed because of disease progression if you don't train. So in Pompe, obviously therapy helps. In ERT, of course, helps, and then we can have a much better peak VO2, a better function, better strength, better respiratory function, activities of daily living. And some studies would enable us to design training programs in other types of GSDs, not fast or easy, but not so as difficult as if there were no studies at all. And the other GSDs with these studies, there are symptoms that can say, let's do a response study and see how they respond. And then in the future, we might continue these training programs. That's the idea behind all of this. I would like to convey other messages to the patients and to the doctors who are here. The first, and I think it's essential to evaluate patients before we design their training programs. And this must be individualized, not just the patient, but their evaluation and supervised. And I'll give you an example later. And in my humble opinion, I hope I'm not too bold, but I think more GSDs could use training. Number 7 hasn't been done. I don't know the results, but I think it would have been okay. And that the design process for these training programs or any strategy, they may be recommended in the clinical guidelines or the position stands also. And paraphrasing the Spanish Association, and all of these studies with many, many people, and the ones you saw yesterday, that's an effort from all of us, from everyone, especially you. You have volunteers who help. Thank you ever so much from all of us, of course. And from Pompe Association, I would like to say thank you for organizing these conferences. I enjoy them a great deal. I think the patients enjoy listening to us, actually. Not only do we tell you about what we do, you tell us what about your situation and when we share panel sessions or evaluations with other clinicians from other countries. Yesterday with Ulrich and with David, I had a wonderful time talking to them. I learned a great deal, and I couldn't be with them all the time to learn more even. This is all, and thank you so much for your attention. Thank you so much.
Muchas gracias. No sé si hay alguna pregunta.
Thank you very much. Are there any questions? May I have just a second? I had this prepared. I like Jordi's strategy. Here it is. Supervised exercise. This is a 5, and even with small children. Look at the very nice things we can do. This is a 5, GSD 5, 7 years old. How they measure the pain and signal the pain. And supervision needn't always be physical. We have a remote access with video WhatsApp. In Brazil, when does it hurt? What's the pain? You can do this kind of video calls and you can refer them. So you see, supervision can be overcome with the technology and willingness. Okay? This was just prepared in case I had questions about it. Okay? Well, thank you. Thank you very much. And now we have Dr. Alejandro de Lucía from the Complutense University of Madrid. We shall understand better the relationship between GSD-3 and training and its viability in type 3 GSD. Okay, how much time do I have? I knew I was coming afterwards, and I thought, oh, probably be less. Okay, I'm very happy. I'm very happy to be here. Thank you very much to the patients and their families for the opportunity of learning from you and to try to help. And it is an honor and it is a pleasure to receive you as volunteers in research. You are the best experts on the disease. Us researchers have to be humble to learn from you, okay, so that humbly we may contribute with our knowledge. Now, effects of training in GSD 3A. I'm going to discuss the heart and other GSD maybe related. This is open access if you're interested. And we sent it to the Journal of Inherent Metabolic Diseases. They didn't even read it. And I think that the 3A GSD should be interesting and relevant. There's very few of you, but the relevance of a disease is not because of how many people suffer it. It's only 19-year-old and hemoglobin is low, and it doesn't matter whether you're 19 years old and you should receive treatment, and the same happens whether you have a rare disease or a frequent disease. So thank you very much to Sue and Almudena and Thomas and Alfredo for all their work and cooperation. 3 years ago, I asked Alfredo, said, let's try to help the 3A, and he didn't welcome the idea, but at the end he said yes. Why? Why are we talking about GSD? Glycogen, when is it so problematic? After all, we're supposed to use it. Glycogen is the way that we store glucose in the tissues. And why do we store glucose in glycogen instead of free glucose? For 2 reasons. First, because of size. Glycogen are thousands of glucose molecules joined together, and so they take up less size. It's not the same storing your money, 1,000 euros in coins or in 2 banknotes of 500 each, right? Well, that's the point. Carbohydrates attract water, and it's much better to have them bound together. And also because metabolism is much better regulated if the glucose molecules are bound together. instead of free floating around. And you're unlucky because of a genetic effect. You are not capable of breaking down glycogen once stored. And like in grape branches, there is a main branch joining the grapes to 1.4 glycoside linkage, and then we have the branching out with the linkage, 1,6 glycoside linkage, and the phosphorylase breaks these enzymes, 1,4 glycoside linkage. And those who have 3A, you have a problem with the D branching enzyme, so you cannot break down the branches. And then what you have are the three branches. No, so here we are. We have two, or better said, three that have a problem with glycogen utilization. That's 9 that we're talking about, it, myocardial disease and others. What's the advantage of myocardial disease? That it will only involve a specific enzyme to be expressed within the muscle. It is a pure myopathy. The other tissues can express the compensatory isoforms. The downside is that the myocardial patients cannot completely metabolize glycogen. 3A, the good thing is that they still have some ability to break down glycogen. It's not fully restricted. And the downside is that this is the only isoform of the enzyme. It is this only one functional, so it is affected not only at the muscles but in other tissues as well. And then Pompe's disease, as was explained yesterday by Tomás, is due to a lysosomal defect. There is an enzyme that undertakes the two functions, the phosphorylase and the differentiation, which is glycosidase. It's like a scavenger function, and the glycogen is accumulated, and at the end you just overcome the ability to store glycogen. In Pompe's disease, it is like there were cytoplasmatic deposits. Okay, 3A, type 3A GSD, have an accumulation of this abnormal glycogen, which is not D branch, and it's a limit dextrin, and it jeopardizes tissue viability because the tissues that most accumulate glycogen, the heart, the skeletal muscle, mostly don't have any other places to store glycogen. Their function is to contract, and they're always full of these contractile proteins, and the glycogen storage has to be well controlled. I'm going to focus on the heart, okay? For any given tissue, we have three main characteristics: the structure, the functioning. When the structure is abnormal, there are some regulatory mechanisms to preserve the function. If we cannot utilize carbohydrates, the regulatory function would be to increase the lipid metabolism as an energy substrate. In the best of cases, we could compensate, like Dr. Weinstein said yesterday, we could achieve this with gene therapy. I don't know whether with exercise we can compensate, but certainly we can regulate better and preserve the tissue function. And that's what we tried to show in this study, okay? It's a preliminary study, an exercise training program for 12 weeks. We think it is relevant and revealing, at least 9 patients, 12 weeks. And the life of a person is nothing. It's very short. So the results call for optimism, I think. The positive outcome of training. There are experts who can discuss training. No, I'm just going to follow your orders. You are the experts. I won't interfere, okay? At the end, we had 60% of the Spanish patients. I'm an exercise professional. It's part of my training, dealing with exercise. And then the effect of the diet is fantastic. When I heard Ulrika the first time, it was so complicated, but at the end, it makes such a big difference. Nutritional protocols make a difference. Those interviews with David and Enrique, where you can see the ketone and glycemic curves are key. I think that Almudena is going to talk about it. But we also think exercise has something to do about it. The outcome, what were our results? Of course, if the people don't follow the intervention, it's pointless. Adherence was almost 90%, so not that bad. It's not only 12 weeks. You have to keep for a lifelong attitude concerning exercise. But at least they performed during the 12 weeks the training, and they decreased the perception of severe fatigue. But the muscle symptoms or the muscle damage didn't change so much. And the quality of life, not so much. I'm always talking. All the patients tell us how well I feel, but no. Then they never show this in the questionnaires. Okay. Well, I'm sorry, I need some water. And then they improved the cardiorespiratory fitness parameters because the VO2 max, as considered by the American Cardiology Association, considers this as a vital sign, as important as cholesterol, heart rate, and so on, and blood pressure, and increased by 15%, which is quite nice. But to play the devil's advocate, no participant achieved the 8 METs, which is the minimum cardiovascular health parameter. Myocardial have metabolic limitations in glucogenolysis, and yet they went over 8 METs, at least 2 or 3 of them, right, Alfredo? So we can be more demanding with all of you. Increase the strength in your lower limbs. You can do it. This has been a cure of humbleness. I consider myself a humble person, but when I was told that the muscle undergoes consumption, there is sarcopenia, well, something like that happened with you. And also, the training was not that intensive. Since you cannot perform glucogenolysis, it had to be very short stimuli, right? Not to stimulate hypertrophy, but at least you can be optimistic. You can fine-tune the training and obtain a great deal out of it. At the blood, we look for function biomarkers. It's not the best way, but there is a very practical proxy way to measure in blood different substances as released by said tissue. Now, here are transaminases, which are correlated to the liver function. But GGT, gamma GT, is the most specifically linked to the disease. The other two, GLP, GPT, are mostly linked to sarcopenia because there are very young fibers in the muscle that express what they shouldn't do, such as liver transaminases. But we are reassured by these results. Other biomarkers, muscular function by CK or CPK. It's given too much importance. It's not a linear marker. It doesn't have a dose-dependent relationship. You haven't 10 times as level if you have 10 times as damage. It's not the same. And muscular damage as such is debatable. Cardiac damage, yes, but the fraction of CK with muscular damage would be a very, very small fraction of the total CK amount within the muscle. And as Alfredo said, there must be quite a stimulus for hypertrophy to take place. The real problem of having too much CK anemia is that it leads to proteinuria, which in turn leads to renal damage. But if you're following the diet appropriately, as Ulrike has shown you, you have some proteins. It may be a cause of concern. I talked to an expert nephrology, and is this such a problem in such a high protein intake? No, not in a healthy kidney. glomerular filtration rate is the same, but I would recommend to measure albuminuria, albumin in the urine, because the GFR is a late biomarker. When it's low, you have lost nephrons, too many of them. Albuminuria is an early marker, and of course, for biomarkers, you look for the earlier markers. You go to the doctor when you're feeling good to check that your analysis turns out well, okay? You don't go when you're already sick. So we would recommend this. I would encourage you to request albuminuria determinations. And now, cardiac damage. I will talk about the heart here. What is pro-BNP? BNP, this is an early marker when there is a high stress of level and the myocytes, there is BNP rise. Pro-BNP shows variability more or less within the range of normality. The troponin, the high sensitivity. Troponin I is a marker of ischemia. Now, if you had ischemic heart disease, so the heart works well in your case and responds well to exercise. Body composition, well, it's not the same. I removed the bad fat, which is the visceral fat, because there was a mistake in the slide, but we couldn't increase your muscular mass. It was only 2 months. We didn't have time for it, but it would be difficult to achieve changes in bodily composition. And now, the heart muscle. We forget about it, but glycogen is very important within cardiomyocytes. It's not that different from skeletal muscle as far as the composition is concerned. They are myofibrils that contract, as Alfredo explained. The important difference is that we have the syncytium physiology, the synchronized physiology, so that they contract at the same time and they are much more bound together. The skeletal muscles have fibers that are more independent, and the cardiomyocytes, of course, has to transmit the electrical signals. So let's see about the deposits of glycogen. Below the sarcolemma, which is the membrane, we will have depositions which are very important for preserving the electrical charges, which is essential for the heart to prevent arrhythmias. Then outside the nucleus, in between myofibrils, but there's not a lot of place to store glycogen. And why do we need glycogen? It's not so important as an energy substrate, not so much as in skeletal muscle, but it could be important in high demand and especially under ischemia conditions. And it's important particularly for development in the intrauterine and the first months of life. The N0 type of glycogenesis, which we are unable to synthesize glycogen, die very quickly. So it is essential, although not yet clarified, but it would be essential. Okay? You remember what Alfredo showed you before? Glycogen would be necessary between the actions in actin and myosin so as to induce the contraction and produce ATP, especially in intensely demanding exercise, and also to preserve the pumps, the calcium pump, which are important for contraction and relaxation, and sodium-potassium pumps for stability, for electrical transmission, which is essential in the heart. Here are some photographs for experimentation animals, electron microscopy, to see that there's just no place to accumulate glycogen. You can't cope with it. And it's dynamic. The glycogen is being broken down, utilizing, resynthesizing, and they go under the sarcolemma, okay, more than in skeletal muscles. The in-between myofibrils, they are more frequent in the muscle. And then in the neonatal heart, there is a huge quantity of glycogen because it's very important for development. So if you have a GSD type 3A, what are your problems? from a heart point of view. This is just to know about it, but not to be worried or concerned about it, okay? There's heterogeneity, variability. There must be. Therefore, regulatory mechanisms to be put into action. In neonatal Pompe, there is no heterogeneity. Enzyme replacement therapy has to be administered as of birth. Okay, even intrauterine administration. In the States, they publish this in the New England. But that is not the case in 3A. There are some people who are completely asymptomatic. In the case of GSD, you don't know whether the severe cases described with a sudden cardiac death are due to purely the 3A type or any other cases, and even heart transplantation has been described, although it's not so manifest as in the neonatal Pompe's disease, but the left ventricular hypertrophy, the hypertrophic cardiomyopathy is to be prevented because it is a very frequent occurrence in the disease. And for this, we need echocardiography. And that's why we call upon you time and again for the test and the MRIs. What do we see? This figure, this is a section of the heart, and especially we focus on the left ventricle. Araceli is the best, so I'm reassured. You have a cardiologist, it would be the best to have the best assessing the heart. Otherwise, I wouldn't be able to sleep. But no matter what the numbers and the papers tell you, they will always know. They know what your heart is about. I called Araceli yesterday, and she told me, no, Pompe patients are doing well. She's a bit of a scatterbrain, but it's okay. There's even the first division football players that are still playing thanks to her. She's a genius, just a bit distracted. Okay. Usually we have a good balance between the walls and the cavities. The worst heart you can have is the eccentric hypertrophied heart with very thin walls respect to the dilated cavity. They are candidates to transplantation. They swell up and they cannot pump the blood, and they're candidates to transplantation. Some of the surgeons operate the child until they wait to transplantation, binding it to the thoracic muscles, but that is not your case. There is a trend to concentric remodeling because of the excessive accumulation of glycogen within the cells, of course. And what is the cardiomyopathy of an hypertrophic kind? Well, some cardiologists call it one way or another, but it means that the left ventricular wall is too thick. And what's the problem? That electric impulses are not sent at the same time to all the different cardiac fibers, and then we can have problems with arrhythmias. And in the worst case, we're talking about ventricular arrhythmias that can cause sudden death. They're very serious, and that's why a implantable defibrillator can be placed, okay?
Sobre todo cuando está acompañada de
And especially when it is linked to fibrosis.
las paredes de vuestro ventrículo izquierdo.
So, what about the walls of your left ventricle? Well, quite reassuring. The MRI results are different from echocardiography. In medicine, we believe in machines to be infallible, but an investigator needs to interpret the data. It's not so easy. They don't always use the same equations and parameters. Who sees the hearts best? Heart surgeons. Professional cyclists had the problems, and the surgeon said, you have a beautiful heart. They can see the heart, watch it contract and stop it. Well, the rest of us use proxies. Okay, well, the posterior wall, as you can see, is to the maximum 9 millimeters. We have the median and the range, okay? The most frequent values. So 9 as an average, sometimes 10, 11, but you don't have such a worrisome hypertrophy, and even decrease with training and with the diet, of course. And children, those who are following the nutritional recommendations told by Ulrika, Susana, and Marta, are doing very well. Diameter, left ventricular diameter increases, which is more or less good, and the capacity of the cavity increases slightly as well. But the question is the proportion. The wall shouldn't be too thick corresponding to the cavity. And you have a trend to experience concentric remodeling. It's 4.42, is good. And as a median value, it seems to decrease with exercise slightly, okay? The p-value for it to be significant has to be below 0.05. That means that out of every 100 cases in at least 95, you will see the trend. And then in brackets, we see the effect size. Obviously, the larger, the better. So yes, the exercise did show a trend to decrease ventricular hypertrophy. And the best parameter is to measure the ventricular mass, the wave as to body surface. And it's about 70, so it's okay. Within the range of sports athletes. Sports have the most beautiful heart, no eccentricity, wonderful, exceptional, with larger cavities and stronger muscles, but with the perfect proportion, okay? And even in children, with just 12 weeks, we can change, okay? Just from 3-4, they underwent from the eccentric remodeling to a normal pattern, and MRI went okay. And there are other parameters. I said we have to look for early parameters. Here is the global longitudinal strength, which is an early marker of the left ventricular function. We usually assess the ejection fraction, which is still seen in all examinations, which is the percentage of blood that is pumped at each beat. And a good heart doesn't experience retrograde blood flow and pumps everything forwards. What's the problem? That 60 or 65% is more or less the same. The ejection fraction is not a fine-tuned biomarker, but with the global longitudinal strain is the ability of the left ventricular to be squeezed, like when you squeeze the laundry to wring out the water, right? Well, the same. And here are the papillary muscles. What are they? They don't even know about it, and they don't even consider this in resonance or echocardio. What is the function of the papillary muscles? They're very pretty. They join through the tendinous cords to the mitral valve, and they make sure that the mitral valve closes and co-opts perfectly so that there is no insufficiency or regurgitation, and you still have to follow them. Okay, results of echocardio and cardioresonance. Well, the dimensions weren't the same between the two measurements. No, that could be expected. But why? Why do we submit you to the washing machine with stress and the contrast so that you could feel the temperature? Why? Because cardiac resonance has an advantage. Araceli is clever, but she doesn't have X-ray vision, But this gives you the quality of the tissue, and for this you need MRI. You can see whether it is healthy or not. The T1, T2, weighted images, and gadolinium, which is the contrast employed, means what the quality of your tissue are. And your situation was normal, no signs of inflammation or edema, and with the contrast enhancement, if it takes too long to fill up with gadolinium means fibrosis, and fibrosis, of course, is a marker for sudden cardiac death, and it's low. And by WhatsApp, the chief cardiologist told me so. So I was reassured. And the right ventricle, which is always neglected, is doing okay, and without pulmonary hypertension. The worst thing that can happen would be pulmonary hypertension. And some GSD are associated, but it is not your case. You won't develop pulmonary hypertension. So you have to be constant with what Ulrika and Almudena says and what Almudena, Suni, and Alfredo tell you about exercise and training. You have to be responsible of managing your own health. It's a bore, but you're like professional athletes. Do the exercise and take the shake afterwards. Those who like cycling, football players, you have to be the same as your idols, sports idols, and I think that you can do very well. Okay? And thank you for this opportunity to contribute to your quality of life. And that's all. Thank you very much. Diet and exercise, but don't ask me. Ask the experts. And continue visiting Araceli every year, even if she's a scatterbrain, because if it's serious, she won't miss it. She's a genius.
Pues su médico es Araceli. ¿Vale?
¿Preguntas?
Are there any questions from the floor? You should probably have a whole bag of questions, but you're shy. Okay, we shall have a very brief break, like about 20 minutes. So it's almost 11. Well, at 20 past 11, we'll meet back again, and then we'll talk about nutrition. Thank you.